Diabetes exaggerates the depression. Depression also aggravates the diabetic process. May have difficulty in coping with stress of taking multiple daily injections, managing their activities of daily life. Negative stereotypes associated with type 2 diabetes can lead to psychological and behavioral issues in patient. Education, counseling and social support are essential. In my opinion, now people are becoming more and more so-called caveman, Guha Manav. They have isolated themselves. Earlier I remember when there is Ramayana and Mahabharata going on Sunday morning, all the family members, including some of the side-by-side people, they grouped together, enjoyed, they laughed, they cried, and they expressed their emotion. Now people has become very, very alone, depressive, always using the smartphone alone, not speaking to others. One of my friends told, in the market, those people are going, more than 70% are above 60 or 70. Young people believe on big basket, etc. If you go to the market, you interact with your friends, your people, you get mental strength, you get support, and you think they are all with you. So, psychological part should be also cared of. Economic issues, if I start very costly medicine by the pressure of the company, I have seen many people do not tell that they have not been able to purchase. They keep silent. I feel that my treatment is failure. So first assess the economic status and then give the medicine. Psychosocial quality of life is a factor which helps in improving the HbA1c and the reverse also. Setting glycemic target, it should be set based on clinical, personal and psychosocioeconomic factors as I have shown. We suggest intensive control in younger individuals without complication, elderly people, multiple complications, particularly cardiovascular, renal, autonomic, neuropathy, dementia, etc. Dementia is a very high risk. Patient has taken one dose of insulin, forgot, and after 5 minutes is taking another dose. This should be taken care of. This is a chart or a plan how I can go for scoring, that is the EDCA score, where some points need to be assessed. Life expectancy based on age in years, long, intermediate, short, we are giving point. If it is a short, that means very elderly, it should be 2. Duration of diabetes, glycemic control history, comorbidities, complication, micro, macro, hypoglycemia risk, personal characteristic, attitude, diabetes knowledge, and psychoeconomic factors like resource, support system, quality of life, economic issue. You put points according to the chart and they come to the total score. If the score is less than 5, this EDCA score, you can go below 6.5 A1C. 5.10, keep at 6.6 to 7.5. 11 to 15, 7.6 to 8. More than 16, 8 to 8.5. Pharmacogenomics, just I discussed, it will help us to decide which drug will act, which drug will go for interaction, which drug will create side effects, and which drug is carcinogenic. Very briefly, metformin better response will reduce GLUT2 transport, and if OCT1 gene positive, that is the incidence in 8%, whatever minimal dose metformin you give, there will be side effects. Sulfonylurea, 3.4 times better acting when CYP2C9 gene is positive. For thiazolidine, again CYP2C8 and SLCO1B1 activity present, action is better. Similarly, DPP4 is CTRB1 by 2 gene, and availability of genetic data in a medical record will help us to start successful treatment from the very beginning. I am not going to details. For all the drugs, sulfonylurea, metformin, thiazolidine, insulin, meglitide, glucosidase inhibitors, GLP-1 and DPP4, they have got some genes which can interpret that treatment will be successful or there will be side effects or drug interaction. These are the genes which are concerned with the efficacy of the GLP-1 receptor activities. These are the genes for DPP4 activity. These are the genes for action of the thiazolidine and also these are the genes. They can interpret HP2 genotype, that whether the patient will develop cardiovascular disease from the very beginning. This chart, you are bored with this, very much tired with this, 2024, I am not going to details. Initially classify the patient, assess the organ complication, if obese, some drug for lowering blood sugar, if cardiovascular disease, SGLT inhibitor, GLP-1, if renal disease, SGLT inhibitor, GLP-1, then you add another drug from 1 to 1. I am going briefly through few cases. 38-year-old non-smoker male, 2-year history of type 2, metformin 1 gram BD, no family history of coronary artery disease. Father 64 years has type 2 diabetes and hyperlipidemia, and his mother is healthy at age 60. Well built, well nourished, with blood pressure of 116/80, weight overweight 90 kg, BMI 24. Physical examination is otherwise unremarkable. Creatinine normal, ACR normal, and A1C 7.6. What treatment should suit this? Using the EDCS scoring which I showed you, is low on all variables, thus the score would be less than 5. This is a young individual with a short duration of diabetes without comorbidities. You try to keep the A1C level below 6.5. Another case, 83-year-old woman, type 2 diabetes, 25 years, A1C more than 8.2, severe osteoarthritis knee, anticipating right knee replacement surgery 2 to 3 months, myocardial infarction 4 years ago requiring a stenting. She also has hypertension and osteopenia. Taking Largin 30 units at bedtime, aspirin insulin based on correctional doses, atorvastatin, metoprolol, eosinophil, aspirin, etc. She lives by herself alone, has a son who visits her once or twice a week and also provides occasional monetary assistance. Overall independent in activities of daily life, orthopedic surgeon referred her to the clinic for improved glycemic control to bring down the blood sugar below 120 and A1C below 6.5. Question is whether we should go to that lower level or not. There is no mention of it. It is likely that she has concurrent microvascular disease, long-standing diabetes. Osteoarthritis is another marker for macrovascular and microvascular disease. His calculated EDCS is coding is 18, and we should not try to lower the A1C below 8. You can go very slowly possible. And if to operate, you will have to operate that level. If I go for very strict control below 7, there will be chances of hypoglycemia.
Sir, can you conclude now?
Yes.
Last case.
Yes. We have included the machine problems also. Thank you. So I am skipping this case and coming to the final slide, that short life expectancy, long disease duration, frailty, comorbidities, advanced diabetes complication all lead to some alteration in the A1C, personal preferences, social educational issues, cognitive dysfunction, psychiatric issue, drug tolerance issue, drug access cost issues. From this, you think whether you will keep the A1C level below 7 or you try to keep it between 7.5 to 8.5. Finally, I want to tell you diabetes is not a flat treatment. You will have to categorize a compartmental decision for the patient. The patient has got nephropathy, patient has got retinopathy, patient has got cardiovascular disease, very elderly age, highly liable to hypoglycemia. In that cases, you decide your scale. I am not asking you to go for EDCS scale all the time. It may take timing. Those who are interested, you can take the slide from them. I request Vijay Padni to allow to collect the slide from my slides so that you can go for in details. But keep it in mind, any fixed school, any flat treatment for diabetes is not possible. Emerging research in genetics, pathophysiology, metabolomics, human behavior as well as longer term randomized comparative trials could eventually yield new information to inform the personalization care. In the meantime, we must develop tools to translate existing guidelines into practical clinical application. More importantly, to develop process that encourage the organized management of patients. I just tell, initially assess the age, assess the duration of diabetes, presence of complication, and then you go for your treatment. Just I am showing you one quotation, all you can change is yourself, but something that changes everything. Between you and me in closed hall, I tell my student, patients suffer more of the doctors than of the disease. I am very sorry, because the disease gives some time. The doctor rarely gives some time. A patient presenting with acute left ventricular failure, who is treated with some drug which can produce some problem, diagnosing it as a case of status asthmaticus or the reverse. Status asthmaticus, you are giving morphine, diagnosing it as acute left ventricular failure. Patient will die within seconds. If that doctor does not treat, another better doctor can survive. So if we change our personality, one of pharma people told me, sir, earlier I used to people list cardiologists, neurologists, chest specialists, diabetologists. Now 90% of people came, they are diabetologists. I make only one small list of 10% non-diabetologists. Those who say, I do not understand diabetes. I am one of them, of the 10%. I still do not understand what is diabetes. With this, I just like to place my gratitude for you for making successful the 10 books, and now the 11th book has come, and I really touch your feet for making my books successful. Thank you for your patient hearing.
Thank you so much, sir, for that wonderful presentation. Other than the very wise and informative talk you gave, sir, your enthusiasm is extremely inspiring and commendable. Thank you so much.
Yes, is there any question?
One question.
Or any comments?
If there is no question, that means everything is clearly understood or everything is nothing understood. So there is at least one question. Not audible, not audible.
Sir, I just wanted to know, is there any difference between a brain in a patient, diabetic brain, and a non-diabetic brain, and are the changes reversible or irreversible? I mean, what are the data regarding this?
I will request you to go my book on neurodiabetes. I have given a separate chapter on brain control of diabetes, and which onset of diabetes, microangiopathy in the nervous system starts. There are problems of recognition, there is problems of memory, there are problems of thought process, everything starts, and we rarely can diagnose diabetic microangiopathy in the brain unless and until there is cerebral stroke. Very often we come across sudden blooding or sudden loss of weakness, we go and we see there are past occurrences of diabetic brain. So I am not going to make it clean. Initially for all patients type 2, I do one blood sugar, one lipid, one uric acid, one creatinine, and now I am doing a liver function test. 70% patients are having so-called MASLD, metabolic associated steatoid liver disease. I do postprandial blood sugar, I do one ECG for everyone, I do one ultrasonography. I am thinking whether we should go more because nervous system we are not properly taking care of. But brain changes are there, and brain is the highest organ for controlling the blood sugar.
Thank you. Thank you so much, sir. It's always pleasure to hear you. So,
thank you, sir, for your presentation. I would like to invite the next speaker, Dr. Supratik Bhattacharya. Please, sir. And I would request our chairpersons to please introduce.
yes, so we have Dr. Supratik Bhattacharya. I think there is no any introduction required. So, he is my very good friend. He has published more than 30 international and national as the first author. He has multiple awards, and he is a special achievements of the Secretary, Organizing Secretary Conference 2024, DRWA, Founder President of the MCOE, Speaker at the various national and international conference, Organizing Chair National Obesity Conclave 2022, International IG2 Summit, and SGLT2 Plus Conclave, and the part of the Organizing Committee for the ACPIM 2021, Diabetes India 2021, and RSSDI Defeat Diabetes Task Force, and also a national scholar and rank holder in the 10th board exam and gold certificate holder in the A-level exam from the United Kingdom, and distinction holder in the medical school and post-graduation. Over to you, sir.
Thank you so much for these kind words of introduction, and a big congratulations to Dr. Patni, our founder president, Dr. M.S. Sandwarwala, who is our present president, and Dr. Partho Bishas, and the entire team of DRWA who has been working year-round very, very hard for this conference. So a big round of applause for all of them. So I'm going to talk about something which is something that you practice in your everyday clinics, and there's no teaching to how you should communicate with your patients. Everybody has their own way of communicating with their patients, and there are certain protocols that we talk about, but you have to individualize and customize how best you can communicate with your patients. Now, I'll first show you the first scenario, which was recorded yesterday. This is a bad communications scenario. So let's play the video. Can we have the audio up?
Yes.
Perfect.
Yes, of course. Yes, yeah, you can come. Yes,
Actually, sir, my reports have come and
yes. Yeah, just be on hold here. Yes, so your reports were sent, and like you were diagnosed with diabetes, and so we should write some medications for you, and we have our nutritionist who is going to take care of your diet. So I think it's happening because you're eating too much of calories, and lots of sweets and all. So we need to cut back on all of that. I'll write some medications for you. You have to start having that, and maybe you have to continue that all your life. Yeah, that's about it for now. You can go. Somebody at the reception will show you where the nutritionist is. I'll send you the reception.
Okay, sir. Thank you, sir.
All right. So this is an example of bad communication. The patient has walked into your clinic. You're engaged on the phone. You're not paying any attention to the patient. The patient is trying to communicate that things might be going wrong. You're not picking up the cues. There are a lot of non-verbal cues that you have to pick up from the gesture of the patient. You're not picking that up because you're not bothered. You are not engaged with the patient. So how many of you think you are going to go and see this doctor? Please raise your hand. Okay, so I think we all agree that this is not something that we expect. So now let's see a better scenario. So maybe another example which will show you how so this is my take. Obviously everybody has their own way of doing it. So can we rotate the video again, please? You're playing from your side?
Hello. Hi, namaskar. Please come here. Please come. Let me do one thing. I'll just switch off this phone and keep it here. Please have a seat.
Thank you, sir.
Let me come that side for you. So I just wanted to have a conversation with you because you might be aware that we had sent your reports. So I just wanted to check what you know about what's been going on.
Yeah, I just found out that my sugar levels are quite high this time.
Okay.
So I was quite worried about it.
Okay. So what exactly do you think you're worried about at this point?
My mother and father, my both parents are diabetic.
Okay.
So I am a bit concerned that even my sugar levels are quite high now.
Yes, you're correct in a way because if you have somebody in the family who has got diabetes, then your chances of you getting diabetes is very high. And that's probably one of the reasons why we wanted to check where you stand at the moment. And we did send in the necessary reports. And one of the reports that we had sent is an average of the past 3 months blood glucose of the HbA1c. So that would tell us how your glucose has been, your blood sugar has been over the past 3 months or so. So we just got the reports back, and it does show that it's on the higher side.
So do I have to take medicines now?
Right. So what we wanted to highlight was that younger you are, we want to control your blood sugar very well. And the reason why we want to do that is we want to ensure that you don't have any complications that arise out of diabetes. So the way forward will be obviously, checking on your diet. So if you give us a recall of what usually you take, and then we'll reassess how your dietary pattern has been, because frequently we see that we can probably cut back on some amount of carbohydrates and introduce some protein and fibers in the diet, which might be helpful. So it might quite be that you are eating all the right things, but we still need to assess that. Along with that, we might suggest some lifestyle changes as well. For example, very frequently, if you don't have a dedicated time when you're going out and exercising or even walking, that might affect the blood sugar. So could you just
But
tell me?
actually, I have a very busy schedule. I hardly can make time for exercises and walks.
Right.
So that is quite not possible for me to arrange for something fully with that.
Right. So I can understand that, and that frequently is a challenge for many people. And what we suggest is that if you don't get it dedicated, say half an hour to do exercises, if you're working, you can just get up and walk for 5 minutes, come back, and again at your own time you can do another 5 minutes. So even this 5 minutes accumulates to about half an hour. That would be an excellent thing to do in the morning. So the other way
I can split up my walking out.
Yes. So very recent, studies have shown that if you do smaller amounts of exercises in bursts, that also is equally helpful. And now you have smart watches, so you can see how many steps you're doing the entire day. So anything between 5,000 and 10,000 steps is quite a good number.
Can you please suggest me a proper diet for this?
Absolutely. So once you're done here, we will signpost you to, you will be going and seeing my nutritionist to sit with you and take a recall of the entire diet that you're having. And we might just, if she feels that, there is a necessary change that needs to happen in terms of either, reducing the carbohydrate count or introducing some amount of protein or fiber, she might be doing that for you.
So for now, do I have to take medicines all throughout my life, or can I just watch my sugar levels for that?
So what we intend to do is that, we want you to be on this diet and exercise for a bit, and then we'll call you back and do the numbers again. And if we see that it's still on the higher side, we might be suggesting some medications for you.
Okay.
Yes.
Okay, thank you so much, sir. So helpful.
My pleasure. And there are some materials online as well on our website, which you can go and check. And I know that, it's difficult to get all your queries sorted on the first visit, and while you go back, you might have some other questions for me as well. I'd appreciate if you write it down so that we can discuss that at our next visit.
Definitely, I'll do that. Thank you so much.
All right. So, it was extensive. First consultation was about 1 minute, and the second consultation that you saw was about 5 minutes. So you're putting in 4 extra minutes for a good reason, because you're building a rapport that's going to stay your entire life. So I think that 4 minutes is something we can invest in our patients if we have that amount of time, and they also deserve that. So we'll show you the general protocol. So this is going to be the flow of my talk today. So we'll talk about the objective, understanding the importance of compassionate communication when delivering a bad news. So anything about chronic disease is a big news to take. So when you say that the person is being diagnosed or is going to live with diabetes for the entire life, that's a life-changing moment. So the person has to take that in, and it's very difficult to take all that information in one go. So as we said, you saw in the video that I said we have materials that are available on the site, and also we can understand that you might not get all your queries sorted on the first visit. So when you go back, you write down your queries, and we will try to address that for our future visit as well. So we need to signpost them so that they feel that they are being taken care of. And we need to Also get them in touch with our counselors who are going to stay with them, and in between your visits, if there is any query, that can be sorted. So principles of communications, strategies for delivering bad news, handling patient reactions, and providing support. So this is going to be the flow of the talk today. Importance of effective communications. We need to build trust between us and the patients. We need to help the patients manage their expectations and emotions. So you need to ask them, what is your expectation from this particular consult? What are you expecting out of this? And we need to contribute better to better patient outcomes and satisfactions. Now, when it comes to breaking bad news, so not necessarily just the chronic disease, but there are many scenarios where you have to break bad news about a person's death, etc., which the patient's family is not aware of. There is a protocol. You need to sit them down first, offer a bottle of water, and then I'll tell you about the spikes protocol, about how to effectively deliver a bad news. So preparation is very important. So if a patient has just come in running and you give them a bad news, they might collapse and fall on the floor. So you don't want that. So you want them to be comfortable. So get them seated. Gather all the relevant information and ensure privacy. So take them to a separate room and make them seated. You need to be absolutely clear and give the message in clear, straightforward language. So you can't go about it. So you need to give a warning shot and then deliver the message and wait. Don't keep talking. Wait for a bit, wait for that news to sink in. Because if it's a bad news, the patient is going to take it badly, and you need to wait for the emotions to come out. And you need to address them after that. So show empathy, show compassion and understanding, and also support, and offer emotional and practical supports. So this is the spikes protocol, which is widely followed. So S for setting. So ensure privacy, as I said, take them to a separate room, get them seated, involve significant others, and sit down. Perception. So again, assess the patient's perception and understanding. So he or she may not be absolutely aware of what has been happening. He might have gone to the office and suddenly got a call from the hospital, and he's coming running. So you need to check what he already knows. Invitation. So obtain the patient's invitation to share information. So wait for the moment till the patient is prepared when you can give the information to the patient. Check the background knowledge of the patient and give information in manageable chunks. So don't keep speaking. Talk, wait, this should be your protocol. Managing emotions. So once you have broken the bad news, there will be a lot of emotions that you have to deal with. So sit with the patient, hand in a handkerchief. If the patient starts crying, offer a bottle of water, hand in a handkerchief. These are the common etiquettes that we need to maintain. Strategy and summary. So once we are done with that, we need to summarize and tell them the way forward. So this is called the spikes protocol. So preparing to deliver bad news, start with a warning shot. What is a warning shot? I am afraid I have some difficult news. Stay quiet for a bit. Let the patient ask you, what is the bad news? And then you deliver. So don't just go about it at your own time, okay? Use simple, direct language. So break the bad news. Say, your father or mother has passed on. Then stay quiet for a bit. Let the emotions come out. She might be crying. Just offer a handkerchief, as I said, or some bottle of water. Pause frequently to allow the patient to process the information and avoid medical jargons. Has undergone cardiothoracic arrest. She doesn't know what cardiothoracic arrest is. So you have to avoid medical journals and speak the language of the patient. So you have to speak in very simple language that the patient can understand. Handling patient reactions. So the common reactions would be shock, denial, anger, sadness, and then finally the patient will accept. So the patient is going through all of these emotions in a very short amount of time, and you need to allow time for doing that. And strategies, allow time for the patient to express emotions, validate their feelings. I can see this is very upsetting. and provide reassurance and follow-up plans. Providing support. So you tell, I can understand that you're going through a lot right now, and you need to actively listen and empathetically listen, offer comforting statements that I can understand what you must be going through. I'm very sorry for what has happened to you. Connect patient with the counseling services if required. Practical support. Provide written information, discuss treatment options and support services, and ensure follow-up appointments, because probably you're not going to address everything in that particular visit itself. So there has to be a continuity. Schedule follow-up meetings to discuss further questions, maintain open lines. So say, I'm available if you want to call me at a later time and discuss. Coordinate with other healthcare professions to provide comprehensive care. And most importantly, one shoe doesn't fit all. And we had been hearing our previous speakers talk about precision medicine, individualization and customization. So we need to talk about and respect cultural, religious and personal values, be aware of different cultural attitudes towards illness and death, and customize the approach based on their cultural context. So this is very, very important. And ethical considerations: respect patient autonomy, don't reveal information about the patient, be truthful, and ensure informed consent for future treatments. So to conclude, as I said, there is no effective way which one shoe fits all. So everybody has their own way of communicating with your patients, and you have become a master of that. Over the years that you had been practicing, you have developed the skills, either by learning from others or by learning to talk with your patients. You have already developed those skills. So this was just a general protocol that we all can use in our clinical practice, but it doesn't mean that we have to follow exactly that. So this is team DRWA, who has been working very, very hard, and a big round of applause for the team DRWA. And finally, it's all about teamwork. So a big thank you to my secretary and the entire team back in my center who had agreed to do the video. And you see here an excellent team of counselors, nutritional professionals who are actively helping us every day to care for our patients better. So a big round of applause for all of them as well. Thank you.
One or two questions can be allowed. How much do you charge for this?
So as I said, you saw the difference between, I always say, why we say drive safely. You can drive at 120 and probably get to the destination maybe a minute earlier. But if you need to be effective, if you need to be safe, you can drive at 80 and go a minute later and still make your family happy about it because you had been driving safely. So it's all about the patient satisfaction. So I think that extra 4 minutes is very important, which we frequently don't give our patients because we are rushed, we are busy in our OPDs. But I think this is something we might consider doing, and how you fit it in is entirely up to you. But as I said, having a good team really helps, because if you don't have all the time to talk to them, you can always signpost them to your counselor who would help out as a team overall, so that the patient is satisfied. They know that they can fall back on somebody.
Yes.
So one question from my side. Suppose there is a team of doctors and patient is not counseled properly about the morbidity he has, and suppose suddenly patient collapsed. And how will you explain him?
Beg your pardon, if you repeat your question again.
Suppose there is a team of doctors, 3-4 people are looking after one patient, and there is a morbidity, and it was not explained properly to the relative and patient, and subsequently collapsed, died. Then I will take care of it.
Correct. So that's an example of a difficult scenario, like we had shown you. So the family is not prepared for this news, So you need to be upfront about it. As we said, when the patient comes, or the family comes, you need to get them seated and then deliver the news the way we said it. Give a warning shot that, I'm afraid we have a bad news for you, and then say that we were not expecting that this would happen, but this has happened. And whosever fault it was, you have to own up to that. If it's a system error, we need to take that into consideration. If it is some individual's fault also, again, it becomes a team's responsibility. So you need to direct them that this has happened, and there are certain forms that you can fill out to, raise concerns about, and we will look into it, or we'll have an investigation into this issue and get back to you on that regarding whose fault it was. And obviously, you need to provide your number so that the patient, if he wants to call up and talk to you, can go about it better.
Can it lead to medical legal issues?
Beg your pardon?
Can it lead to medical legal issues?
It obviously can, and majority of the time, I'll tell you my personal experience. I'd worked in very difficult places where mortality was very high. I was in a tertiary cardiac center where difficult cases used to be referred from all over the place. And since I could communicate with the patients and give them the real scenario and get them prepared for it, majority of the time, I never had any complaints at all. But if you don't communicate properly, it will definitely end up in cardiological aspects.
Thank you, sir.
Thank you so much, Dr. Supratit, for wonderful, as usual, for talk. I think.
Thank you so much once again.
Yeah, thank you, sir.
Thank you, chairpersons.
Thank you, sir, for your presentation. And thank you to all our chairpersons. And we would like to give out the mementos. Ma'am, please. And our speakers, Dr. Alkananda Ray, Dr. Lily Rodrigues, Dr. Mary D. Cruz, and Dr. Firdaus Sheikh, and our rapporteur, Dr. Amit Dey. Please come on the stage. And Dr. Alkananda has just arrived. She will be joining you all.
Very good afternoon, one and all. We are very happy to present in front of our mentor, Dr. Samar Banerjee, the GDM session. And you all know that we have been talking about diabetes, so many things, comorbidities, complications, what to write, what not to write, do all that. But is it possible? Can we prevent diabetes itself? Yes, we can, if we focus on the fetus, that is the pregnant mother. What all we should do during pregnancy to grab diabetes from its roots, we are going to have some interesting points which hope you all will follow and help in making all adolescent girls fit to conceive, because you all know David Parker, he has told that all these non-communicable diseases arises in utero, and long back in the history Chanakya has told the fate of the child, everything depends on the mother. So coming to the gestational diabetes, which is the diabetes, any glucose abnormality occurring for the first time during pregnancy. We'll discuss this in a case-based manner. There is a case of 24-year-old female, married. She comes with 2 months missed periods. And of course, her height is 160, weight is 78. and she has a history of mother and maternal auntie diabetic. Her BP is normal 110/70, pulse 82. So, my panelists, how you are going to proceed with this case? Dr. Alok, would you like to say, when will you screen for gestational diabetes in this lady?
So in this lady, I will screen her in the very first antenatal visit, because GDM can occur in any trimester. And in 1/3 of cases, actually, GDM appears early in pregnancy. And hyperglycemia in the early months of pregnancy needs to be diagnosed and treated because it can cause embryopathy if there is increased blood sugar levels. And also, very importantly, when there is maternal hyperglycemia, it causes increased transfer of nutrients and mixed nutrients as well as glucose to the fetus. And in the fetus, the placental beta cells, the pancreatic beta cells, they appear as early as the 7th week of gestation, and they differentiate by the 10th to the 11th week, and by 11th to 15th week, they are secreting insulin in response to these nutrients. So when there is maternal hyperglycemia and in turn fetal hyperglycemia, it results in fetal hyperinsulinemia, and these beta cells, they get primed, and they have a very exaggerated response to glucose challenge subsequently, and it can result in what is popularly known as the fetal glucose steal. And it so happens that because of fetal hyperglycemia, which results in decrease in the blood sugar levels in the fetus, so that causes a gradient across the placenta, and this promotes a flux from of the glucose flux from the mother to the fetus. And so if you're doing an OGTT maybe in later weeks of pregnancy, it can actually attenuate the results, and you may get even a false negative result of OGTT. So that is why it is very, very important that we diagnose it very early in pregnancy. And so you might get actually a false negative result of OGTT if you have missed the early weeks in pregnancy. So that is why I'm going to investigate her as soon as she comes in the very first.
Thank you, Dr. Alok. You are saying that very early we need to investigate, because the early weeks the organs are going to develop. If she misses, she can go in for congenital anomalies. And again, 11th week the fetal pancreas starts secreting insulin in response to mother's blood sugar. So if you miss in the early weeks, the later part after 10 weeks, the fetal handling masks the GDM in the mother. So after that, if you screen, you may not diagnose GDM at all. This again and again, what you have told clearly, once the fetal cell, it is triggered, it will fire forever. That hyperinsulinemia during pregnancy and later in life, this is the cause for all problems. That is our non-communicable diseases, what we are fighting for. And now, yes, you have told so many problems. Now we have to screen for GDM. Dr. Lily, will you explain us how to screen for GDM according to our national guidelines?
Yes. National guidelines have emerged in the recent past from the evidence. And the evidence is one-step screening test for a mother, pregnant mother who comes for the first visit. That's very important. So we have to note that every pregnant woman who comes, whether it is first gravida, second gravida, whatever, previous pregnancies, each time the first visit is the time when we screen them. And the screening, how to screen them is without regard to the previous meal. You give them 75 grams of glucose and ask them to consume it within half an hour in 300 ml of water, mixed in 300 ml of water, and they should consume it within half an hour. And then you do a 2-hour blood sugar test, and if it is more than 140, it is diagnostic of gestational diabetes. And there needs to be followed up since then for gestational diabetes. So that is the national, and this is accepted by the government of India, and it is now called as universal screening method for our nation.
Thank you, Dr. Lily. So you're saying whether the patient comes in fasting or non-fasting state, we have to give them 75 grams load of glucose and see the blood sugar at 2 hours. If it meets or exceeds 140, it is very easy to say that she is a gestational diabetic. The same time which is impaired glucose tolerance outside pregnancy is, here in pregnancy it is gestational diabetes. So now you have found out she has. And again, one thing I want to say, if it happens to be negative in the first visit, mostly you have to do in the first trimester, then you have to repeat in the second. Again, if it is negative, repeat in the third also. Once positive, you need not repeat. She is branded as GDM, so just follow her as GDM. Yes, now we have diagnosed. And other thing, whether we need to screen every patient, Dr. Mary, we want to know whether to screen every pregnant woman or selected.
This is a one-line answer. All pregnant women have to be screened at the earliest, which is the first trimester, or whenever they report to the gynecologist. There are many high-risk groups which we look at, but they are all included in this statement. So they could be elderly primate, they could be obese, they could have PCOD, previous history of large baby, or a bad obstetric history, any of these conditions. But all women have to be screened irrespective of their risk.
So thank you, doctor. You are saying that we need not wait for the risk to happen, then screen. Instead, in our country where the incidence is 11 times more prone, we have to screen every woman. That is universal screening for gestational diabetes. Yes, we have now diagnosed. Again, I want to know why you are so specific about this single test procedure. Dr. Firdaus?
Okay, ma'am. So there are certain advantages of our single step procedure. Firstly, it is convenient, it is practical, it is cost effective, and as ma'am already mentioned before, it does not require the pregnant women to be in a fasting state. It can be done in a non-fasting state also at any point of the day. Most of the time when the patients, they come to the OP, they do not come in a truly fasting state. And many elders who accompany them, they believe that the pregnant women should not be kept fasting for a long period of time. So if we ask them to come for a follow-up again, then there might be dropouts. We might miss many GDM cases. Also, the majority of the chunk of the patients, they go to the PHCs, where there is usually a shortage of staff, shortage of reagents, electricity is a problem, drinking water is a problem. So our one-step procedure is very easily accessible, affordable, and in such a resource-limited setting, it can be incorporated easily. Thirdly, it allows in early detection, thereby timely management can be done, and we can have a better control of our patients. And most importantly, one single test can save 2 lives. So these are some of the advantages of our one-step procedure. Just adding to what ma'am had mentioned about the 75 grams OGTT, if in case vomiting occurs within 30 minutes, then we need to repeat the test the following day. However, if the vomiting appears after 30 minutes, then you can continue with the test. We don't have to repeat it again.
Thank you, doctor. You want to say that in a lower socio-economic country like us, we need something easy because of so many problems, what you said, so that we can diagnose and treat a lot of GDM cases. Thank you. Now we'll move on to the next case. Here is a 29-year-old patient with a BMI of 26 who was diagnosed to be GDM in this pregnancy, which was controlled by insulin and metformin. But she delivered a baby. No slides. This is discussion. She delivered a baby weighing 2.3 kgs. So, what are the instructions you will give to the patient after delivery? Follow up, Dr. Alok.
So now that the patient has delivered, this is a very golden opportunity for us to counsel her, because about 30 to 40% of women with GDM in the next 5 to 10 years, they will develop type 2 diabetes. and maybe in another, in 20 years, almost 50% of them will develop type 2 diabetes. So they need to be told that increased BMI and a sedentary lifestyle are the two most important reasons for type 2 diabetes, and they can delay the onset of type 2 diabetes if they are careful with their weight, if they lose the weight that they have gained during pregnancy and maintain a good, nutritious, balanced diet and an exercise. And usually what happens is GDM is because of the placental hormones and the insulin resistance that arises due to it. So once the delivery occurs and the placenta is removed, we'll find that this effect of the placental hormones, they dissipate very quickly, and almost immediately or maximum within a week, the woman will go back to her pre-gestational, euglycemic state. So we will have to, obviously she was on insulin and metformin, so those need to be stopped immediately. And if the patient, this was a normal delivery or cesarean, I think I missed it, but if she has delivered by cesarean section, we usually on day 3, we will do at least one fasting blood sugar to see whether the hyperglycemic state has reverted back or not. Because a small subset of patients diagnosed as GDM will be unrecognized type 2 diabetes, probably detected for the first time during pregnancy. So that is a routine that we followed in our hospital. So on day 3, we'll do a fasting blood sugar. Or if she is a vaginal delivery and she has gone home within the 24 hours, then on day 7, when she's coming for a checkup, we do at least one fasting blood sugar. Then at 6 to 12 weeks postpartum, we advise 75 gram 2-hour OGTT. And based on the cutoffs, then we find out whether she is diabetic already, or she is not diabetic, or she is having an impaired glucose tolerance. So various guidelines recommend various methods of screening. NICE recommends a fasting blood sugar, but ACOG, and we also follow the 75 gram OGTT. So a fasting glucose of less than 100 and an OGTT less than 140, then we will tell her that she is not diabetic right now, but she has a moderate risk of developing diabetes in the near future, and so she should take care of, have a healthy diet, have an exercise protocol in place. And if it is between 140 to 199 OGTT, or if the fasting glucose is between 100 to 125, then we say that she is having impaired glucose tolerance, and she is at a very high risk of developing type 2 diabetes, and she should definitely take care of her weight, her BMI, and exercise and diet. And she should be told that this OGTT screening should be done at least annually, once every year. If not possible, then at least once in every 1 to 3 years. And she should definitely come for a preconception counseling whenever she is planning her next pregnancy. And we must screen for her for overt diabetes when she's coming to us, when she's planning to, in the preconception counseling, when she's planning for her next pregnancy. And of course, if she is not diagnosed as diabetic, then she should be screened for GDM very early once she conceives. Of course, if she's detected with diabetes, then she should be referred to a diabetic.
Thank you, doctor. Here in this case, what they should have done when she was carrying the baby, they would have come out, they would have known that the baby is IUGR. She was on insulin and metformin. Because of the baby was small, they should have stopped the metformin. Again, you are stressing, saying the importance of postpartum follow-up. This is equally or more important than antepartum care. Because here only you are going to prevent diabetes both in the mother as well as the child. So for the follow-up, you see the blood sugar. In some cases, if it happens to be true GDM, she becomes normal. She may not require any insulin or treatment. Even meal plan, she'll revert back to normal because it was totally due to placental stress. Placenta delivered, everything gone. But in cases pre-GDM, you have to follow with the blood sugar monitoring. Mostly the dose gets halved. What they were using, it will not come back to normal. We may have to halve the dose of insulin. And here, what usually in those days we used to say, we have to check at 4 to 6 weeks, but it is very difficult to catch them back after delivery they run away. So what they have found, they have done a study in US and found at the time of discharge, 3 days later, all revert back to normal. So you just do a blood sugar test that represents the same, like how you do at 4 to 6 weeks. Then you have to repeat after 6 months, then annually and every birthday of the child. Here it is possible only you have communication with a pediatrician where they usually go. They will not come back to us. Thank you.
Madam, is it 100 or 110?
And after delivery, the values change. For pregnancy, fasting less than 90 and diagnosis 140. Whereas after delivery, the fasting, it's enough if it is less than 100. And 140 is impaired glucose tolerance, 200 is diabetes. The value changes. Thank you, doctor. Then, in this case, so, yes, you have told what you have to do for the mother. Now we'll see to the child. Dr. Lilly, what will you do for the baby?
Yeah, I think this is one of the very important question. Although we are physicians here, most of us, we cannot say that our job is over, we have taken care of the mother, but we need to look at the baby. If no pediatrician is available, we should know what to do for the baby. So first of all the vitals of the baby needs to be checked, and then look for any anomalies which are missed otherwise during the follow-up of the antenatal care. And then if the baby is active enough, check the blood sugars of the baby. So that should be done within the first half an hour after the delivery. So that is the most important thing to do so that we don't miss the hypoglycemia in the newborn. So that's one of the very, very important thing that we all can, we should remember. And what is hypoglycemia in the newborn is also to be known. If it is less than 45 or less milligrams, or 2 millimoles. 2 millimoles is 36 actually. But here what we take is 45. If it is less than 45, that is considered as hypoglycemia in the fetus, and less than 36 is bad.